necessary. Okay, so this morning we're going to chat about triglycerides, what and why. So last week, quick recap, there's two types of fat or lipid in your blood. Cholesterol, which most people have heard of, and we'll just do a recap on that. So can anybody give me a reason why cholesterol is important in the body? Why we need cholesterol?
We need it to make bile, I think. Was it bile?
Yeah, we need it to make bile. It's in all our membranes or cell membranes. And we also need it for hormones and vitamin D. Okay, so cholesterol is really, really important. The problem with cholesterol is if we get too much cholesterol in our arteries, it can clog it up, fatty plaques, okay? And there's two types of cholesterol, HDL and LDL. Can anybody remember the kind of bad cholesterol or the one that we don't want too much in the arteries? LDL. Excellent, yeah. So LDL is the type of bad cholesterol. So we know all about that. We know the LDL clogs up your arteries. That can happen in your heart, cause a heart attack, can happen in your head, can cause a stroke, or can happen in your legs, cause peripheral vascular disease. So today we're going to chat about triglycerides, the kind of lesser known fat, I would suggest. Okay. They're another type of body fat or lipid. And again, they're measured as part of your lipid profile, and we'll come back to that later on this morning. We'll chat about what kind of, if you get your lipids or your blood fats measured by the lab, either with your GP or in a hospital environment, what kind of results you're going to get. But triglycerides are composed of 3 fatty acids and a glycerol molecule. Okay, so that's what a triglyceride is made of. And the glycerol molecule basically comes from glucose, from sugar, in a process called glycolysis. It's one of the first processes of the breakdown of glucose. So we can make fat from glucose, and that's quite important. And I'm going to come back to that in a wee while, okay? What do we think is the main role of triglycerides?
Is it energy? I don't know.
It is energy. Yep. Okay. So that's why we store fat. It's an evolutionary thing. Okay. We store fat because essentially at one stage we may have clubbed something over the head, eaten it, and then maybe not eaten for 3 or 4 weeks. All right. And the whole idea was any excess food that we took on board at that stage was stored as fat, and then we could use that as an energy source. All right. And from an evolutionary point of view, that hasn't changed. When we eat, we store excess food as fat, okay? When we've replenished all our glucose and glycogen stores. So essentially what we do when we eat is the carbohydrate is broken down into simple sugars such as glucose. We store that in our liver. Can anybody remember the molecule that glucose is stored as in the liver?
Glycogen.
Glycogen, yep. So glycogen is the big storage molecule, and glucose is also stored in your muscles as glycogen as well. Two big differences though between the liver and muscle. Muscle's quite greedy, so it takes your glucose, it converts it into glycogen, and it sits as glycogen and glucose in your muscle ready to be used, but it just stays within that muscle. Whereas your liver is the big area in the body that you store your glucose and glycogen for the rest of your body. So at 3 o'clock in the morning, when your blood glucose levels drop because you haven't eaten for a while, you've been fasting, your glucose is your liver is the big organ that will keep you slow release of glucose to keep you happy, keep your brain happy, and keep your glucose at a constant level. All right. Now, when we have excess glucose, or indeed we can do this with protein as well, you can convert protein into glucose if you need to, but excess glucose is converted into fat. So where do we get triglycerides from? We get them 2 sources. We get them from our diet. So we can either eat fats that are broken down into triglycerides, and our liver also produces triglycerides. So it's a wee bit like cholesterol. Some of your cholesterol comes from your diet, and the rest is produced by the liver, and it's the same with the triglycerides. So in terms of dietary triglycerides, essentially what happens is you eat something with fat in it. So you eat meat or a dairy product or oils or fats. They're absorbed they're broken down, so essentially mixed up in the stomach, go into your small intestine, and at that stage, your gallbladder releases bile, and bile's kind of the fairy liquid, so it breaks up the fat into little globules called micelles. These are absorbed into your blood, okay? And the big fluffy particles with lots of fat in them are called chylomicrons. And chylomicrons are the first stage of fat that's been broken down from your digestion and absorbed into the blood. And again, as for cholesterol, the triglycerides and the fat have to be combined with protein, because fat will not mix with your blood, because your blood's essentially about 60% water. Okay, it's very aqueous. All right. And then as the chylomicrons go through your blood system, they'll get routed towards the liver. But en route there are enzymes actually in the inside of your arteries that are stripping things off the chylomicrons. So by the time the chylomicrons get to your liver, there'll be what we call chylomicron remnants. So they'll have been changed quite a bit. Some of the fat will have been removed, proteins will have been added and removed, etc., etc. And then the chylomicron remnants go round to the liver. Now, at the same time, your liver's also making triglycerides. All right, so same as cholesterol, there's a process in your liver that's making triglycerides. And your triglycerides can essentially be stored for energy. All right, they're stored for later use. When you have a reduction in insulin, so if you're in the non-fed state and you reduce your insulin secretion, that can result in an increased breakdown of your triglycerides into fatty acids and glycerol. And essentially that is what happens when you don't eat and you become ketotic. So sometimes in the morning, if you don't eat straight away, you might have a funny smell in your breath because you've produced ketones. And that's essentially just because some of your triglycerides have been broken down into fatty acids and glycerol, and your body's using fatty acids as a source of energy. All right, so that's where the ketones come from. And we'll go into that in a wee bit more detail when we do the session in diabetes in a couple of weeks' time, because I'll chat about what happens when you're a type 1 diabetic and you get diabetic ketoacidosis. All right, because it's the same kind of mechanism. Now, you ingest fat and that adds to your triglyceride load and your liver produces triglycerides. We'll come back to how your liver does that in a wee minute. But one of the other main sources of triglycerides is actually carbohydrate. Once you replenish your glucose stores in your liver and your muscle, any excess carbohydrate, and by that I mean refined carbohydrate, so the simple sugars coming from cakes, sweets, biscuits, and things like that, or indeed white rice, white bread, etc., potatoes that are broken down really quickly. Any excess refined carbohydrate essentially is converted to fat. All right, because that's what our body does with it. We want to store energy, and we can only store so much glucose and glycogen. Glycogen is a huge molecule. There's a lot of water in glycogen. And I think it's something like for every 3 pounds of fat or 6 pounds of fat, it would be about 10 times the amount of glycogen. So can you imagine hoofing that around with you? All right. Because you know what it's like if you've lost 5 kilograms or 10 kilograms. Alex has done the thing that, you put it in a backpack and you hoof up and down the stairs or go out for a walk and you're thinking, whoof, that's quite difficult. And that's the amount of weight you lost. Well, if we stored all our energy in glycogen, we'd probably be about 3 or 4 times the size. All right. We'd be huge. All right, so that's why we only store a certain amount of our energy in the form of glycogen, because it's got a lot of water in it. And that's why if you go on a ketone diet, you lose weight quickly to begin with, because you're essentially breaking down your glycogen and you're losing a lot of water. So what do I mean by refined carbohydrate? Refined carbohydrates are easily broken down to glucose, and then they can be converted to fat for storage, which results in an increase in your triglycerides. Any questions about any of that? I think the big take-home message is fats in your blood are not just to do with the fat that you take in your diet. Okay, that's the kind of take-home message I'm trying to get across here. The fats that we store is also related to carbohydrates that we eat as well. Okay, but it's the type of carbohydrate we eat. Now, back to the liver making triglycerides. I spoke last week when we were chatting about cholesterol that the liver makes VLDL, very low density lipoprotein, which is then converted into LDL eventually. Well, the VLDL is another type of triglyceride, okay? So when we measure triglycerides in the lab, when you get that triglyceride result, it includes your chylomicrons and the VLDL. That's basically your two sources of triglycerides. Now, that's really complex. You don't really need to be aware of that. And I never chat about chylomicrons and VLDL to my patients. I just chat about triglycerides. That's the measurement that I will chat to when I'm chatting to my patients. So measurement of triglycerides, essentially when you go to your GP and you get your lipids measured, you get a lipid profile, you will get a total cholesterol done. And the total cholesterol is the figure that 5 millimoles per litre is the figure you've probably heard of. And if your total cholesterol is more than 5, everybody gets quite excited. I don't get quite excited, all right, because it's not as simple as that. Okay, they showed years ago in the 80s and 90s that once your total cholesterol was more than 5, there was an increased risk of heart disease. But we've got better risk calculators now that look at, your total cholesterol and your HDL ratio and things like that, and lots of other different parameters. So it's not simple as that. And they take into consideration your age and things like that. However, you will get your total cholesterol. You also get your HDL and your LDL, and then you get your triglycerides. Okay. Now, when you get your lipids done, we used to always try and do fasting profiles. We don't do that anymore because we know the fasting profiles don't make a difference to your cholesterol levels, your LDL or your total cholesterol. Arguably, you could get a fasting profile done for triglycerides, because your triglyceride level will be affected more by how far you are post eating. Okay. I have a morning clinic, but I still don't get fasting triglycerides done. And the reason why I don't is because if you take someone's normal day, they probably on average fast for 8 hours versus 16 hours of your non-fasted. And in terms of your cardiovascular risk, I'm happier knowing that what your triglycerides are for 2/3 of the day as opposed to 1/3 of the day. So do you get that? We used to do fasting triglycerides all the time, but I'm not actually that bothered about that, because if I get somebody to come into clinic fasted and they get their triglycerides done, that's just showing me what their triglycerides have been overnight, or not even all of overnight, probably only the last 4 or 5 hours. Okay. Whereas if I get them non-fasted, it gives me an idea of what their triglycerides are like for 2/3 of the day or 16 hours of the day. All right. So what level should your triglycerides be? The figure is 2.3 millimoles per litre. Okay, which is low, okay, especially when I've met patients who have triglycerides of 15, 20, 40, 50, 60, and we'll get back to that in a wee minute, okay. So triglycerides should be, your fasting triglycerides should be less than 2.3 millimoles per litre. All right, any questions about any of this? No, I've wowed everybody into silence. Right, okay, so how do you get problems with your triglycerides? What results in elevated triglycerides? Bit like cholesterol, there are primary causes. Okay, so a primary cause is genetic. So in cholesterol, when we chatted about high cholesterol, you could get the genetic predisposition to having high cholesterol, which was familial hypercholesterolemia, FH. And it's the same for triglycerides. There are primary causes. You can have a genetic insult or a genetic mutation that runs in the family that results in high triglycerides. There's 2 or 3 different types of these, and I'm not going to go into their names. So you can either have high triglycerides in their own, you can have a mixed pattern, which is high triglycerides and high cholesterol, and then you can have incredibly high triglycerides. All right. And I'm not going to talk about those. We don't find very many of those in clinic. In fact, I'm not too sure if I have anybody. I have in other clinics I've worked in within the health board I work in, I've met, but I don't think I have anybody in my books at the moment. Okay. And that's because the majority of people with high triglycerides is secondary causes, and it's due to lifestyle. Okay, so this is probably the most important thing for you guys. So the 3 top causes of having high triglycerides are truncal obesity or weight around your abdomen, type 2 diabetes or insulin resistance, and alcohol. And I have patients with all 3 hits. Okay, so those are the 3 main secondary causes of having high triglycerides. So what do I mean by truncal obesity? So this refers to your body fat distribution. And it's really important because this is one of the big drivers for your overall health risks. Really, really important. I often say to patients, I don't care if you've got a bottom the size of Florida, not bothered at all. But it's this, and this is really kind of taking off because there's a big cardiometabolic medicine is kind of coming to the fore at the moment because of all the research that's going on. And it's all got to do with this weight around your abdomen and how that's linked to your overall health and your cardiometabolic health. So how is fat stored? Two areas in the body it's stored.
Under your skin.
Yep. And do you know the term for that?
Subcutaneous.
Okay. And can anyone else tell me where the other fat storage is? So we've got subcutaneous under the skin.
Around your organs.
Yep. And can you remember now? It's a wee bit more difficult. Can you remember the technical term for that? Or does anybody know? Visceral. Yeah. Excellent. So you've got subcutaneous fat, and most people have got a little bit of that. All right. And then when you've got weight around your abdomen, there's a lot of it is called visceral fat. It's around your organs. So it's around your liver. Now, it won't just be around your liver. It's probably around your kidneys and around your pancreas, etc., etc. But that's a chat for another day. But the big organ that becomes fatty is your liver. Okay. And in terms of females, you'll see more of this postmenopausal because you're bum to tum, essentially. Premenopausal, when you lay down fat stores as a female, you will do it around your hips. And that's essentially for childbearing purposes. It's so that you can mobilize energy if and when you get pregnant and have a baby. And then when you go through the menopause, any fat you lay down will go more around your abdomen. So it's more truncal distribution. So that's kind of the apple shape versus the pear shape. And men will lay down in an apple shape, 10 years, 15 years earlier than females. Okay. Now, that's not saying I don't have 30-year-old females in my clinic who don't have abdominal fat. They can. You'll only lay so much around your waist, and then you'll lay it around your or your hips, and you'll lay it around your waist, around your abdomen. Okay. So why is this truncal fat important? Well, it's all tied into insulin resistance and chronic inflammation, which is all tied into cardiovascular risk. So when you lay down fat, you get a fatty liver. And essentially, this is, you can get this thing called NAFLD, or non-alcoholic fatty liver disease, or MASLD. I did a chat about this a couple of weeks ago on the live when I eventually got on. Spoke about it for about 20 or 25 minutes. So essentially, and briefly, your liver is essentially full of glucose and fat. And at this stage, your liver can't take on board any more glucose or fat, and the excess glucose is converted to triglycerides, and that falls out. The triglycerides fall out into your blood, and that's what we measure, and that's kind of what we call ectopic fat. So you've got subcutaneous fat under your skin, you've got visceral fat around your organs, around your liver, and then when the liver has got too much in it and it can't do anything because it's full of glucose and it's full of triglycerides, those triglycerides then fall out into your blood. We take a blood sample, and that's essentially what we're measuring. Okay. And it's all linked to insulin resistance. Insulin resistance makes it more difficult for your cells to take up glucose. All right. You're shaking your head, Louise. I don't know whether that's just because this is all too much at this time of the morning.
No,
insulin,
sorry, it wasn't to do with anything you were saying, sorry.
Insulin resistance results in increased VLDL production, which is increased in triglycerides as well. Okay. So that's kind of where the truncal weight comes in. When you have truncal weight, you've got a fatty liver, and excess triglyceride production in the liver spills out into your blood, essentially. And this is all driven by insulin resistance. Alcohol, what does it do? And I often, if you have someone who drinks quite a substantial amount of alcohol, the first thing I will do in clinic is ask them to abstain for 6 weeks, and we repeat the lipid profile at this stage to see essentially the effect of alcohol on your triglycerides. And it can be quite, you know, someone can have triglycerides of 15 or 20 millimoles per liter, and they abstain for 5 or 6 weeks, and their triglycerides can actually come right back down to normal, or 3 or 4 millimoles per liter. Alcohol results in an increased VLDL production by your liver as well. And alcohol also affects, can make your liver fatty as well. That's one of the first changes you'll get if you drink a lot of alcohol as well. So combination of the above, if you're overweight, you get weight around your abdomen, and you drink quite a bit of alcohol, that results in increased triglycerides, and also your insulin resistance. Because when you're insulin resistant, we know that you've more than likely got a fatty liver and you've got a lot of glucose already in your liver. Okay. In terms of diet, the big thing that affects your triglycerides is not fats per se, it's your intake of refined carbohydrate. Okay, refined carbohydrate, not carbohydrate on its own, refined carbohydrates. A big one of this would be full fat fizzy drinks. Okay, I'll have a lot of patients who will admit to drinking 2 liters, 3 liters, 4 liters of full fat fizzy drinks. Okay, and one of the big things is you literally stop that, and the triglycerides will just bottom out, come right down. Okay, and if it's not the full fat fizzy drinks, if they're drinking diet drinks, it's likely to be with cakes, sweets, crisps, etc., etc. So I do a full nutrition screen when people come to clinic to see what they're eating and how we can adapt that as well. Okay, so that's how you get your high triglycerides. What are the problems when you do have high triglycerides? High triglycerides, as well as cholesterol, are increased with increased cardiovascular risk. All right, and also increased pancreatitis. So pancreatitis is inflammation of your pancreas. It can be very serious. If you get pancreatitis, inflammation of your pancreas, that can result in you being hospitalized in high dependency or intensive care. It can be very, very serious if it's very inflamed. There's no real treatment for pancreatitis. They kind of give you supportive treatment. They'll give you fluids. They'll be nil by mouth, plus or minus antibiotics, depending if there's any sepsis involved. But it's kind of a wait and see approach. You just give them supportive care and see how you get on. If you have recurrent bouts of pancreatitis, you can actually damage your pancreas, and you can become a diabetic, because, it's not a type 1 diabetic, it's diabetes secondary to pancreatitis. Because you don't produce insulin anymore, but it's not the normal route of getting type 1 diabetes, which is an autoimmune response. Okay. Your cardiovascular risk is also increased. And also the thing with having elevated triglycerides is tied in with metabolic syndrome. So metabolic syndrome is a collection of things that have been grouped into something called metabolic syndrome. So to have metabolic syndrome, you have to have 3 out of the 4 of, say, high blood pressure, insulin resistance or type 2 diabetes, elevated triglycerides, and a low HDL, and usually truncal weight. So that's 5 things. And if you have 3 or 4 out of the 5, or often if you've got 1 or 2 of those, I'll say, oh, you've got a metabolic phenotype, and the chances are if you don't change things, you're going to, you'll end up with metabolic syndrome. What's the problem with metabolic syndrome? Increases your risk of cardiovascular disease and type 2 diabetes and non-alcoholic fatty liver disease. They are all linked. Okay, because if you've got the high triglycerides and the low HDL, the chances are you've got a fatty liver. If you've got a fatty liver, the chances are you've got weight around your abdomen. If you've got weight around your abdomen, you're likely to be insulin resistant. Insulin resistance and type 2 diabetes does not happen overnight. They think you probably have a fatty liver about 10 or 15 years before you develop insulin resistance, and then you may have insulin resistance for 10 years before you develop type 2 diabetes. These are not all things that happen overnight. Okay, it's things that have been going on in your body for quite a while. So that's the bad news. The good news is, all right, and there's always a silver lining, is lowering your triglycerides is easier than lowering your cholesterol, I would suggest, by diet and lifestyle. Sometimes people can make changes and they can alter their cholesterol quite drastically. I've got patients, though, that have altered their lifestyle quite drastically and their cholesterol hasn't moved. Not the same for triglycerides. Okay. Triglycerides are really responsive to changes in lifestyle and diet more than cholesterol. Okay. So you can really make a big change with your triglycerides. So, can we see if anybody's got any suggestions for what you should do?
Caroline, can I ask, you mentioned 4 things in the metabolic syndrome. I got the high blood pressure, the low HDL, and high triglycerides. I missed the 4th one.
Truncal weight.
Truncal weight, thank you.
And yeah, plus or minus insulin resistance or type 2 diabetes. Okay, so there's probably 4 or 5 things. And the other thing in metabolic syndrome would be gout. So I would often check a uric acid in patients who I think have got metabolic syndrome, because the chances are they've either had gout or they're about to get gout. They're all related. Okay, and metabolic syndrome will be associated with chronic inflammation, although we don't really have a marker for that.
Okay, thank you.
All right. Okay, so changes in lifestyle and diet in terms of your triglycerides. Can anybody give me what they think they could do to lower their triglycerides if they were found to have high triglycerides?
You mentioned walking there this morning at the start was good for it.
Yep, so exercise. So what does exercise do? Exercise decreases your insulin resistance. All right. So, oh, no problem, Jackie. Right, exercise does quite a few things actually. So exercise itself can decrease insulin resistance. How does it do that? Exercise allows you to get glucose into cells without actually using insulin. So it decreases your requirement for insulin. And I often say, if somebody's insulin resistant or type 2 diabetic, please move and move after particularly after you've eaten a meal. Okay, but get those steps in, really, really important. Exercise will also help with weight, and exercise itself is also supposed to help your liver irrespective of weight loss in terms of your lipids. Okay. And presumably that's got to do with the fact that if you're exercising, or not exercise, moving, it doesn't even have to be exercise, just moving, being active, going out for that walk, doing the ironing, doing the gardening, just not sitting on the sofa. So there's a difference between exercise and being sedentary. They're 2 different things. So you can exercise, you can go to the gym 5 times a week, knock it out for an hour as hard as you like. But if you're sedentary for the rest of the week, you're not at your optimal, your metabolic health is not optimal. So you have to do, you set aside your, as Alex said this morning, you diarize, you get your Google Diary, you diarize your gym sessions, but you also have to get your steps in, and you have to get them throughout the day. So my advice to people who can't do a lot of steps, if you're only doing 2,000 or 3,000 steps, don't do them all in one go. Split them up. I'll often chat to patients about they can't walk very far, they may be older, they may have problems with their hips, their knees, etc., etc. So 10-minute exercise snacks, 10 minutes of walking. And that's really useful for family members, older family members, or people who have issues with joints or mobility. So exercise snacks are really good. But you want to move, because moving gets glucose into your cells. And also, if you're getting glucose into your cells to be used for energy, the glucose is not being jam-packed into your liver. Okay, so it gives your liver a wee bit of a break, and then any glucose that's required additionally, your liver will release, which again gives your liver more chance to take up more glucose if it needs to, or indeed use some triglycerides. Exercise or regular activity will also affect your weight, and a decrease in weight will eventually help your truncal weight. Okay, we know it doesn't necessarily come off there straight away, we get that, but if you keep working at it, it will come away. Decrease your saturated fat. Okay, again, that's all got to do with your cardiovascular risk. We do not want a diet high in saturated fat. The chances are you don't, because if you've gone through TSD, you'll know with saturated fat, you don't get a lot of bang for your buck. Going way out a 20-gram block of cheddar. Again, a mouse wouldn't even be happy, but it's about 80 or 90 calories. It's horrendous. You can increase your unsaturated fats. So where do you get unsaturated fats? Oily fish, and again, avocados, nuts, etc., etc. Decrease your refined carbohydrate. That's probably the one piece of advice I always chat to patients about. Refined carbohydrate makes a huge difference to your triglycerides. If you're a diabetic, whether it's a type 1 and you're overweight, or type 2, good diabetic control will affect your triglycerides, the better your control. And also decrease your alcohol intake. That's really important as well. Okay, so any questions about that? The other thing to do with triglycerides, which I would also suggest to patients who've got a metabolic phenotype is I would suggest they try and do a 12-hour fast overnight. Now, I know that doesn't tie in with all of the TSD things, and I know Alex is very keen for people, especially if they're trying to lose weight, to possibly, he always has a snack, I think, before he goes to bed, etc., etc. I think if you've got a problem with your triglycerides, doing at least a 12-hour fast is probably quite useful. Okay, it just gives your liver a rest. And that's something I'm working on at the moment. Now, I didn't, full disclosure, did not do this at the beginning of TSD. I would have always had something later on in the evening before I went to bed. But now I'm trying to, and I'm fortunate I've lost the weight. I'm trying to maintain the weight loss. But what I'm trying to do now is think of my metabolic health, which is another stage. But you've got to remember I'm 4 years down the line. All right. So one of the things I'm trying to do is now introduce at least a 12-hour fast, if not longer than that. And again, that is just literally to let my liver do its thing and have a rest. I think there's also quite a bit of evidence to suggest that's good for your gut microbiome. I'm not a specialist in that in any shape, way, or form, but I have done a lot of reading about it in the last 6 or 12 months. And I think it's quite good for your gut bugs too. All right. So if you have high triglycerides, if you've got a genetic predisposition, it can be actually very difficult to deal with. You have to be really careful with your diet. And by this, I mean, there are people who come in, there are people who have a problem with their triglycerides, and they will have triglycerides up as high. So less than 2.3 is kind of healthy, 50, 60 millimoles per liter. Now, when you have triglycerides that high, you're often, we discover their triglycerides are that high is you come into hospital, you may come in with chest pain or abdominal pain and it's pancreatitis, or you may come in with some other problem. Anyway, they take bloods and the serum. So when we spin the cells down to the bottom in the serum, which is the liquid part of your blood, which is essentially mainly water, yours will be straw colored, okay, and clear. You will be able to look through it. And that's where we measure all the things in the lab and we shine light through it. That's how all those tests are carried out. If you've got triglycerides of 50 or 60, it will be like milk. You will not be able to look through it. And we can't give results. So lots of times people come into hospital, they haven't asked for a lipid profile, but they've come in with whatever. And next thing, we'll knock everything out. We won't be able to give liver function. We won't be able to give kidney function results at all. And it's essentially because our analyzers can't do anything with the sample. We'll go and look at it and it'll have flagged up that it's lipemic. And as a result of that, we'll spin it, we'll get rid of the fat, then we can do the measurements. But we will also measure the lipids. And this is when we will then phone the ward and say, okay, the total cholesterol is 10, but the triglycerides are 60. And at this stage, we get asked, oh, what medications do they need? They don't need any medications. They need to not eat. They need to be put on a drip for fluids for 24, 48 hours, and the triglycerides will come down. And then you investigate what the problem is. Did they have pancreatitis? Did the triglycerides cause pancreatitis, or have they drank a serious amount of alcohol in the last 2 or 3 days? Or are they got metabolic syndrome, etc., etc. And they've just had a whole session with refined carbohydrates. If you stop the refined carbohydrates, if you stop the alcohol, their triglycerides will come back down to a lot lower levels. Okay, and then you can do further investigations. Ethnicity is important as well, and this is really difficult because I've shown you this before. When you go into the BMI calculator on the NHS website, you now can put in ethnicity, whether you're Asian, whether you're Caucasian, whether you're Afro-Caribbean, etc., etc. And that all affects when they deem your healthy body mass index. So Caucasians 18.5 to 25, whereas a lot of the Asian ethnicities there will be 18.5 to 23. So I have patients in clinic who have a BMI of 24, 25 and will have high triglycerides. They will have dyslipidemia. And you just look at them and you just feel for them because, you know, they walk outside and they can see people who are, you know, have a lot more chunk of weight than they do, and they already have a metabolic issue. And that's really difficult because I have to ask them to get their body mass index down to 22 to see if they can improve their lipids. All right. So you can have a genetic predisposition. If you do have a genetic predisposition, you'll have a discussion regarding diet. It's very important, but there are also medications that you can be put on for high triglycerides. First line medication used to be fibrate, which brings down your triglycerides, but we now know that statins, the treatment that we use for high cholesterol, actually serve you better in terms of cardiovascular risk. So if you've got high triglycerides, the first medication you will probably be put on is a statin, and then it won't affect your triglycerides that much, but it does protect you in terms of cardiovascular risk. And then if your triglycerides remain above 10 millimoles per litre, you'll be put on a fibrate, which decreases your triglycerides in your blood. Okay, but there's a lot of work that still needs to be done with diet and lifestyle. That's going to make the biggest effect. Okay, if you can lose weight, if you can move more and alter your intake of refined carbohydrate and alcohol, and control your diabetes well, or if you're type 2, put yourself into remission or make yourself insulin resistant as opposed to type 2 diabetes, that will go a long way into altering your triglycerides. So, any questions about that? That's a lot of information this morning. It's also a lot of information on something that I guess you don't talk about when you go out for coffee with your friends or in the supermarket. Cholesterol maybe, but not triglycerides. All right, triglycerides are something that people don't know a lot about, but I think will come to the fore in the next few years, because really tied into cardiometabolic syndrome, and people will start chatting about triglycerides a lot more. Okay. And it's definitely something the cardiologists are looking at now as in terms of cardiovascular risk. They try and get your cholesterol sorted out, and then after they've got your cholesterol sorted out, they'll start looking at triglycerides. Okay, no questions? So just to summarize, I don't think anybody's put anything. I'm not very good at, here, the chat. Will you see this for a laugh? There'll probably be about 20 questions in here. Great info, thanks. Right, okay. So just to summarize, your triglycerides from your liver and also your diet. So your liver health's really important. Your diet's really important. Increased refined carbohydrate and alcohol will affect your triglycerides. A fatty liver will affect your triglycerides. Main causes are secondary. So it's elevated body mass index, weight around your abdomen, type 2 diabetes or insulin resistance, and alcohol. You can have, I have come across TOFIs before, thin in the outside, fat in the inside. So you can have people with a BMI between 20 and 25, Caucasians, who still have elevated triglycerides. So they obviously have a fatty liver. All right. And that's just life. Medicine's an art, not a science. Okay. But the majority of people who have high triglycerides will have, you know, BMIs up late 20s, 30 plus. Okay. Alcohol is important. So the big thing with triglycerides is a lot of it is controlled by lifestyle. So that means you can do something about it. So keep moving. Moving is really, really important. Why is moving important? Because of insulin resistance and getting glucose into the cells where it can be used. Okay. Being sedentary is a really, really big issue. Coincidentally, Alex was talking about this morning. How do you get your steps in? So if you live reasonably close to a supermarket, I don't, we live out in the middle of the sticks. It's a backpack and away you go. And I'm thinking, no, I do the whole car parking thing. I've done that since I joined TSD. So never use the escalators, never use lifts, always take the stairs. Car park, yes, I will park further away and hoof the bags back with me if I can. Although I'm very bad at remembering my bag for the supermarket. Alex would not be impressed with this. I end up usually filling the trolley and then pushing the trolley to the car and then having to empty the whole, and he'll think that's so cost or so time inefficient, and it is, but I'd rather do that than get a bag because we don't need any more bags. No. So I'll put it into the boot and then I have to, at least when I get home, I've got bags I can put it in and carry it back into the house. But yeah, so I'd be doing well to remember a bag, let alone getting a rucksack. But yeah, so keep moving would be my top tip for triglycerides and refined carbohydrate. Those are your two keys to keeping your refined your triglycerides down. Okay, just before I finish, any questions? No. Okay, so I think next week we're going to move on to the world of diabetes and insulin resistance and things like that. Okay, so we'll do a little bit about type 1 and type 2 diabetes, but that's next week. Okay, right. Have a fantastic week. Keep walking. All right, so no matter what your steps are, get a few more in this week and it will stand you in good stead.
Thanks,
all right,
Caroline.
have a great day.
Caroline.
Thank you very
Thanks,
much.
Caroline. Bye.
Okay.
It was very
Take care.
interesting.
Bye.
Bye.
Very
Bye.
interesting.